So EGFR is activated in approximately 60% of glioblastomas. This is one of the reasons why from the get-go, people in the field suspected that EGFR had a pathogenic function in this disease and was therefore an attractive therapeutic target. Not to mention, EGFR had already been targeted in other cancer types, such as lung cancer, with great success. But it was, early on realized that the success that people had seen in lung cancer was not being seen in GBM, despite the fact that EGFR activating lesions are actually more common in GBM compared to lung cancer. And so the issue then became that the type of resistance that you get to EGFR inhibitors in GBM is different than the type of resistance that you get in lung cancer, because in lung cancer, you actually see a response. And then these tumors come back and are refractory to these therapies. In GBM, they're resistant from the start. So it was a more difficult question to answer in the context of de novo resistance. Now, what are some of the potential mechanisms of resistance? One I already mentioned, which is the loss of the tumor suppressor PTEN. So PTEN is a phosphatase that antagonizes the function of a lipid kinase called PI3 kinase, which is a prominent oncogenic pathway in most human cancers. And so PTEN dephosphorylates the lipid products of PI3 kinase, and by virtue of that, if you lose the activity of PTEN, then you get accumulation of PIP3, the main lipid product of PI3 kinase. Now, this then activates a myriad of downstream effectors that people think bypasses the requirement for EGFR activation. And this is how the field thinks activation of PI3 kinase pathway causes resistance to EGFR inhibitors. And so one potential way to overcome that mechanism of resistance is to combine PI3 kinase inhibitors with EGFR inhibitors. But this presents a couple of different challenges. One is that clinical trials looking at these types of combinations have shown that this is difficult to do because of toxicities associated with this type of combination. The other one is that there's very few PI3 kinase inhibitors that are known to penetrate the blood-brain barrier currently in clinical development. I can only think of one or two examples of such drugs. And even those, we don't really know whether they will be tolerated in the context of a combination regimen with an EGFR inhibitor. So some of the things that people in the field are trying to do is really understand what is downstream of PI3 kinase, and whether any of those signals could be therapeutically targeted in a way that would be more viable from a clinical point of view in terms of combining two different drugs and eliminate some of the toxicities.